Good afternoon. It is 12 noon here in Central Illinois, so we are going to go ahead and get started. Welcome, everyone. As you come in, if you are having any issues with technology, please let us know in the chat. Welcome to the Crisis Residential Association's webinar, Breaking Free, Substance Detox and Treatment in Crisis Settings. My name is Neolita Span, and I will be serving as your host and moderator for this afternoon. So the Crisis Residential Association is a 501c3 nonprofit organization dedicated to exist to support the operational and clinical functions of crisis residential programs around the world, rooted in the values of empathy, recovery, and continuous improvement. Our organization seeks to connect providers with the best ideas in behavioral health treatment to transform the way people receive mental health care. So if you are wanting to be a member, please let us know. Being a member of the Crisis Residential Association has some benefits to it. We get discounts on conference attendances. We have access to all of the CRA webinars as well. So if you would like to be a member, you can go to www.crisisresidentialassociation.org and click on Become a Member. Okay. So we are going to go over some housekeeping items for this afternoon's webinar. So the GoToMeeting platform allows people to submit questions through the Q&A portal or send chats to the host or presenters. However, chat between participants are disabled, and everyone will be muted for this webinar. If you have any questions at all that we will answer at the end of this webinar, please submit your questions through the Q&A portal located in the controls of your GoToMeeting app or website. Today's webinar will be recorded. Recordings are available for all members of the Crisis Residential Association through our website portal. If you're interested in becoming a member, again, please visit www.crisisresidentialassociation.org and click on Become a Member. Our presenters have provided free resources pages that are currently in the handout section of this webinar platform. Please, you can download those at any time and in that section. You will also receive a survey via email at the conclusion of this webinar. We appreciate any feedback as it helps to inform our future webinar offerings. Now, I'd like to introduce our presenters to you, Jamie Brewer, who is currently listed as Travis Atkinson, and Elon Javanfard. Jamie Brewer is a passionate and experienced licensed therapist and leader in behavioral health with over 14 years of experience in the field. Jamie's expertise lies in crisis intervention, program development, and acute community work with kids and families. Jamie previously spearheaded the development and implementation of crisis stabilization and crisis respite programs and oversaw mobile crisis walk-in, and co-responder programs. She currently leads the Intensive Family Services Program at Mental Health Partners in Boulder, Colorado. Jamie balances a rewarding career with a fulfilling personal life, spending time with her husband, young children, and dogs. Welcome, Jamie. Elon Javanfard is a psychotherapist who specializes in reintegrating the whole self by utilizing present-focused methods of discovery and coping. He received his training in multiple highly sought-after clinical rotations, working alongside a multidisciplinary clinical team to treat chronic and severe mental illness in a low to no-cost community-based clinic. Mr. Javanfard has a broad range of clinical trainings that he has utilized in multiple settings. He is the Division Director of all Crisis, Residential, and Substance Services for D.D. Hirsch. Currently, he also holds a seat on the board of the Crisis Residential Association and is an adjunct professor at Pepperdine University's Graduate School of Education and Psychology. Please welcome Elon Javanfard. you guys can take it away.
All right. Welcome and thank you everybody for joining this presentation on the importance of integrating substance detox and treatment services into crisis residential programs. Crisis residential programs provide a critical support to individuals who are in acute distress, but often they overlook the connection between crisis and substance use. So in this presentation, Elon and I will explore why and how to integrate substance detox and treatment services into these kinds of programs.
Thank you, Jamie. So let's level set and give ourselves some time to review our expectations and objectives for today. What we're going to do is we're going to elaborate a little bit more on knowing the reason that substance treatment services are essential within residential care. We're going to discuss and learn a little bit more about how the benefits of providing those services in these types of programs, some of the pitfalls and challenges related to identifying how to provide care for substance users in residential crisis settings. Lastly, we're going to hopefully identify some programming and evidence-based approaches for providing substance treatment in these settings, with some resources and suggestions to provide you as a group to be able to incorporate some of the clinical detox work into your own residential settings as well.
Awesome.
I'll go ahead, Jamie. Let's go with yours first.
So we just wanted to provide you guys with a little bit of background, why are we qualified to talk about this subject? So I previously worked at a different community mental health center in the Denver metro area. At that center, I started and operated a crisis stabilization unit there. It was a 16-bed unit with a length of stay of 3 to 5 days, max of 5 days. We had both voluntary and involuntary beds, so individuals could be there on a mental health hold. Although our unit wasn't considered a locked unit, we were a secured unit. We had nursing staff and what we call behavioral health techs, which are bachelor's level techs, and they were on staff 24/7. And then we had therapists 7 days a week, and we had prescriber coverage 5 days a week plus on-call staff. Additionally, we also had peer support services that were there on site 7 days a week. Unfortunately, this program is no longer operating at this time, but this is what I am gonna, base the majority of kind of my knowledge in this area around, is operating this unit. And then I additionally started and operated a crisis residential unit as well that had similar components that I may reference also.
Thank you, Jamie. And I myself am in Los Angeles at D.D. Hirsch Mental Health Services. Up until recently, we had 24 crisis residential beds. We currently operate one program. We've had to consolidate the program for reasons not specific to this training, where the length of stay is 28 days. Our average length of stay is 16 days within the program. It's also a voluntary unlocked facility. There are paraprofessionals or counselors 24/7 within the program. We have a prescriber and nursing team who are there 2 to 3 days a week, depending on the needs of the programs as well. And within that setting, we also have therapists and care coordinators on a daily basis. And one of the things we offer at this program is a clinical detox protocol to monitor people that need to be clinically detoxed off substances. And we'll talk a little bit about the difference between clinical detox versus non-clinical detox. We also offered monitoring of self-administration of medication to provide medication supportive services. And this program has been operational since 1990. I'll add one other component, which is I also oversee a 40-bed drug treatment facility, which functions under the ASAM model of care. So it's a residential, high acute, high need residential program, which also has a detox component, and therefore a lot of the information that is incorporated into this training comes from the strictly substance treatment facilities and substance treatment locations that have been incorporated into crisis residential settings as well.
So all that to say, you know, between Elon and myself, we've worked in a lot of different types of settings that are crisis residential, crisis respite, and other types of substance treatment settings. So we're really pulling from all of these places in our knowledge as we talk about this subject here today.
To help us level set, we're just going to add some stats that I think are important for providers to be aware of themselves, particularly for providers who have emphasized the majority of their career on the mental health side and less on the substance side as well. So we know that 1 in 4 adults currently are living with a serious mental health problem also has a substance use problem. It means that the co-occurrency is about 25% within this population. Roughly 46 million people met criteria within the last year for a DSM diagnosable substance use disorder. This number has continued to climb in the post-COVID world as well. In the year 2021, there was a report that was completed that I think is really important for a lot of us to be aware of, that 94.5% of people with a substance use diagnosis did not receive any formal treatment whatsoever. What that means, and it's a work group that has now, according to the research in the year 2023, increased to roughly 97%. We call this 95%, reaching the 95%. It's a work group where it's designed about how to offer substance treatment services in non-substance treatment settings, because that is oftentimes the most impactful place you can find an individual who needs help when it comes to substance issues. Patients admitted for substance use or drug use or abuse or overdose into hospital settings typically stay in hospital settings longer than other patients will as well, therefore taxing the hospitalization system and impacting the crisis system overall as well. We also wanted to just provide a little bit more information about the comorbidity that can occur when it comes to mental health and substance use disorders as well. So mental health conditions oftentimes, and in my opinion, almost always, precede substance use disorders, because oftentimes substance use is primarily a unsafe or unhealthy coping mechanism to address whatever the mental health conditions were that were untreated with an individual. And therefore, there is a higher prevalency of untreated mental health disorders that are associated with people who have substance use, particularly those who develop substance use disorders at earlier ages. It's this idea, as I mentioned, of the self-medication hypothesis, the idea of the neurobiological self-regulation theory, that individuals are going to find and seek some kind of coping mechanism that is going to help soothe them and is going to help them recover from the functioning that they're struggling with pertaining to their mental health conditions. And therefore, you couple that with the fact that most substances have a high level of tolerance and withdrawal and have an addiction component as well. You create this feedback loop of mental health conditions being treated by individuals themselves with substances, and the substances exacerbating the mental health conditions, leading to the comorbidity that we will see frequently. So why should you be providing substance services? Well, besides for a lot of what we just mentioned prior in regards to meeting a person's level of care and providing them what we would consider to be whole person care, I'll mention a few of the really important components on this slide, and we'll elaborate on them as we go along. When you are offering an individual substance services within a crisis residential setting, you are individualizing their care more specific to them and their needs. You're identifying not just the disorders that they may be experiencing, but you're individualizing the functional impairments and symptoms that they're experiencing to be able to offer them better services. It leads to improved outcomes as well, because oftentimes individuals who are experiencing substance use symptoms who do not have support when it comes to their sobriety or do not have support when it comes to their withdrawal or their detoxing are less likely to remain in your program and meet the needs that they have pertaining to the rest of their mental health conditions as well. It continues on the spectrum of continuity of care to ensure that you're offering individuals the full scope of what may help them and what may provide them with support to be able to live a functional life outside of a residential setting as well. And I'll tie that very closely to holistic care. It's the idea of whole person care, ensuring that you're treating not just the mental health conditions, but anything that's co-occurring, including substance use, including medical conditions that may exacerbate a lot of the things we mentioned. The last two, which are most important to me, are the idea of skill development, which is that a person who comes into a setting that is there for a crisis is there because they may not have the requisite skills and coping skills to be able to live the functioning that they want to live and thrive on a day-to-day basis. And therefore, they may be using, as we mentioned, substances to help mask or cope with the day-to-day struggles they have. If we can provide them with skill development, we are simultaneously treating the crisis and the substance as well. Last and most importantly, in my opinion, would be the stigma reduction. There continues to be, while we've made tremendous strides when it comes to stigma of mental health disorders and stigma of mental health conditions, there still is a lot of room for us to make progress pertaining to substance use disorders. There still is this entrenched idea that while a mental health condition can occur to somebody, a substance use disorder was primarily their choice. They chose to be an addict. They chose to use drugs. And therefore, even in our field, in our settings, we ourselves stigmatize this population in some ways. And one of those examples is here, living in Los Angeles. We have two distinct bodies and entities when it comes to care. There is one agency and overseeing government operations that oversees substance services, and another one that oversees mental health disorders. And they don't commingle due to the fact that there's an idea that there's a different need for substance population providers than there are to be able to offer them care in a mental health setting as well. So I think it's really important for us to take those things into consideration as we level set some of what we can help share with you today.
And, I think a lot of us here in this presentation are probably on the same page with all of these. And these are things that we know that, we see every day that impact the work that we do. But sometimes it's really nice to just kind of like have this list. If you need to make an argument to your leadership or to your stakeholders or to your funders about why we need to be integrating SUD treatment into these types of programs and why it is so critical to have this type of care.
So for those who are familiar with the ASAM or the ASAM model, the ASAM is the diagnostic tool that helps you support and identify what level of substance services an individual requires and needs. Many crisis residential programs, and we'll talk about pure respite as well, many crisis residential programs are already receiving clients who would fall into the substance use disorder system of care, frequently identified as these levels within what's called ASAM level 3. To level set information for a moment, level 1 is what would be considered outpatient clients, clients who just need ongoing outpatient support and services for substance use. Level 2 would be individuals who need intense outpatient services, or what would be called IOP, several days a week, several hours a day, possibly. Then level 3 would be residential care. And within residential care, there are different levels of intensity as well. There are people who fall into the low intensity of mental health symptoms who find themselves in substance use facilities. And there are people who find themselves in the higher intense populations, which is the 3.3s and the 3.5s. There's also a really fascinatingly important system of care within this umbrella that's called clinical withdrawal. And these are individuals who do not need to be hospitalized due to their substance use and do not need a hospital setting to help withdraw them. They can actually withdraw within other residential programs, possibly on their own, or possibly with the support and care of caregivers. That is an individual, that is the type of population that could be within a crisis residential system of care. And on the pure respite side, we're seeing that pure respites can take the gamut of these individuals within their system of care as well. Oftentimes people have a sponsor or had a sponsor in their lives as part of their outpatient recovery system while they enter a peer respite. And our ability to possibly work with those individuals and also work with their supporters when it comes to their substance treatment is going to be a vital component of their care as well.
So as you guys think about the programs that you are running and operating, and we talk about in the rest of this presentation kind of how that might look and some of the barriers that you might encounter, be thinking where in general you may be able to offer a certain level of care at your program. For example, the crisis respite that was at my agency, we were a bit unique in that we were only staffed during the day. So there were no staff there overnight, and there was a bar right across the street. And so in our respite, we only took individuals that met an ASAM of, a level 1 or below because of those factors. But in our crisis stabilization unit, we accepted individuals all the way up to a level 3.2 because we were able to manage that given that we had nurses on staff 24/7. Towards the end of that unit's lifespan, we actually moved to a different location and we switched our model slightly, and so we only had nursing 7 days a week at that point, and so we dropped down to a level 3.1 that we were able to offer. So where your programs are able to kind of fit into this model is really going to depend on what your staffing looks like and how you run your model. But regardless of those factors, you should be able to find somewhere that you can still offer SUD services within your program, on this continuum.
So some of the similarities that we find within the ASAM model, so the system of care that's available for addictions medicine, is comparable to the system of care that we try to aspire towards within crisis residential systems as well. This would be the idea to begin with of a holistic approach. Both the ASAM model and the crisis residential model consider this approach where it's not just the primary symptoms or issues that the person's experiencing, but it's their overall well-being, including their entire mental health system, their emotional system, and their physical health conditions as well. Both systems also take an individualized treatment planning approach into place. They conduct comprehensive assessments, we individualize care, we take a person's strengths and challenges into consideration. We develop treatment methodologies and interventions that are going to offer both systems as well. We offer groups, we offer individual support, we can hopefully offer family conditions and support at times. Most importantly, seen in crisis residential settings, especially ones like the one Jamie described, where the model of care is a shorter length of stay, is the idea of coordination of care and coordination of services. It's wonderful that they stabilized with us and they stabilized in our setting, but are we going to get them to move along the continuum of care to find more individualized and specific programs to help them focus on the support that they need? While in the time they're with us, we connect them with other peer support, we connect them with educational resources and counseling resources, we connect them with whomever it is that is going to help their recovery journey go forward. Those are two things that are done primarily in these both types of systems, in the substance world and in the mental health world. Because the overarching goal in any of these systems of care is to help a person stabilize and find their way back to whatever their baseline is or what their baseline should be. Helping them minimize the acute mental health conditions they're experiencing, and helping them stabilize their substance use disorders, because again, we know they go hand in hand. As one exacerbates, the other one increases as well, and vice versa. Lastly, and most importantly, especially when it comes to a higher level of substance use disorders as well, is the integration of medication management into these sites, is ensuring that we have the ability to offer psychiatric medications, particularly medication-assisted treatment, which we'll call MAT, the majority of this talk, which are going to help people minimize a lot of their cravings and symptoms pertaining to their substance use, and are going to help them be able to remain or reside in other residential forms of care a little bit longer and hang on a little bit harder when it comes to those jonesings that they're having for the substances that they're seeking. These similarities help us understand that the two systems of care, while they may be separate at times, and while the background of training for some of the individuals who go into specialized substance use disorder treatment versus mental health acuity treatment may slightly differ, there are a lot more similarities to these systems and a lot more that can be done with the individualized staff we currently have than we may have thought of to begin with.
Now, we know that, you know, in an ideal world, it would just be really easy to integrate, you know, SUD services into our mental health services. And gosh, that process would just go so smooth and be, you know, easy peasy. Yet that's not how our world operates right now. So let's just take a quick look at what are some of the challenges and barriers that a lot of us encounter when we get to the point of trying to integrate this work together. So, you know, we have a fear of risk that exists for a lot of our staff and our providers, our leadership, our stakeholders, right? The neighborhoods that we're in. This can look like concerns from our nurses or concerns from our medical providers about adverse client harm and, you know, their license, and will they get sued or things like that if something happens with a client. And gosh, ultimately as the provider, you know, my license is the most important, and so they don't want to integrate, you know, detox or things like that onto a unit. We have therapists and we have, you know, peers or techs that may be concerned that they can't be responsible for individuals who are maybe experiencing withdrawal symptoms because they've never done that before. So there's a lot of fear of risk that we have to mitigate as we get a program like this up and running. You know, Elon already talked about stigma and what that looks like. So we have, you know, not in my backyard, right? If folks learn that you're integrating substance treatment, sometimes there can be pushback from your neighborhood or stakeholders, depending on where your program is located. You know, we still have a lot of stigma around, you have to have really specialized, you know, certificates. You have to be certified in being able to work with SUD. You have to have all of these specialty things. It's not easy to get those. And that's just simply not true. So we really, you know, we struggle sometimes ourselves as providers with being able to get over some of those stigmas that are associated with treating substance use disorder. Licensing can be a major barrier for folks, right? So a lot of you might be asking, well, you know, in my state, licensing to provide SUD is different than licensing to provide mental health, and the two cannot mix. So therefore, I can't do both on the same unit, right? And that ties right into billing. How do I bill for SUD services versus mental health services? I have to bill them separately. I can't bill them overlapping. What codes do I use? You know, how do I work with commercial insurance through this? So again, those things tie together oftentimes as a barrier. And cost, right? So we might be providing more services that you might not get reimbursed for. Do I need extra staff if I'm going to add this level? Do I need other equipment? So we wanted to really call out a lot of these challenges and barriers that, you know, both Elon and I have experienced in our programs, and we're sure that you guys are experiencing some, if not all of these things. But don't worry, hang on, because we're actually going to speak to how you can break down these challenges and barriers and still provide these kinds of services, right? So how do we do it, right? This is like kind of the crux of the thing here.
We also want to be intentional and mindful that if there were any challenges, if you came here with any specific challenges in mind and Jamie didn't mention them so far or doesn't mention them in the how to do it component, please feel free to put that into the Q&A and put that into the chat, into the information, so we can definitely make sure we have time to address those as well, or culminate them and synthesize them into the information you're about to hear as well.
Yes, absolutely. yeah, we want to make sure that you guys have really good information, that you have some takeaways that you leave with today that you can go and act on.
I want to
So,
just share.
oh, go ahead, Elon.
Want to just share a quick
Yep.
story of the integration of this and what it looks like, despite all the barriers that you may see or we may experience in programs as well. One of our programs is, for those who are football fans, is right next door to the new Rams Stadium here in Los Angeles. And we had a client who lived with us for a long period of time and was able to work on his sobriety and be able to get sober. And he actually went back to school and became a substance counselor. During that period of time that he went back to school, COVID hit, and he started to experience a lot of loss, a lot of pain, a lot of struggle in his life. And he started using substances himself again and left his position and his job. And he struggled with identifying how he was going to find himself again and get back on his feet. It happened to be that year he was watching the Super Bowl, and the Super Bowl was happening here in Los Angeles at where the Rams play, and the Super Bowl that the Rams actually won as well. And the blimp flew over the stadium, and while he was watching the game, and he mentioned he was intoxicated at the time, he saw the entire city of Inglewood and realized, oh my God, that's the program Excelsior House that I got sober at. And he called during the game to ask to come back to the program. And one of the things he mentioned that worked for him well in that system of care, despite a lot of other places being available for him, was the integration and the lack of stigma that he felt sharing that he was a substance user in a residential mental health setting. Knowing that he was going to get both systems of himself taken care of, his whole person being taken care of, is one of the functional reasons he felt able to come back and able to go back on his journey towards recovery as well.
Thank you, Ilan. I know it's often so helpful to hear those positive outcomes and stories, the real life examples of how this looks and how this works. So you want to now integrate substance treatment into your crisis residential or your crisis respite, your peer run respite, or maybe even your crisis walk-in center as well. Where do you start? How do you do it? So as with most things, a really good place to start is making sure that you have screening and assessment that is set to build your program for success. So we want to make sure that you have a comprehensive measure, because that's an essential component that we use as we get into this to help mitigate risk and to ensure that we're delivering the right service to individuals at the right time. So we want to make sure that we have an accurate identification of, what's going on for that person, right? What substances might they be using? What have they used in the past? What are they currently using, right? What's on board for them right now in this moment? How significant are those symptoms for them? What are they experiencing? Not just the substances, but also in terms of mental health, right? Because those, like Elon pointed out earlier, play in together. This will also help us to have really good and accurate admissions, right? And we're making sure that the people that are coming onto the unit or coming into the house or the program that you have are in the right place. And putting these things into place, again, helps to assure your staff, your leadership, your stakeholders that you guys are mindful of risk and that you are taking all the steps to ensure that you're minimizing risk and that you have procedures in place to speak to those things. This also helps with your program evaluation to see if you guys are being successful, right? You have to have your baseline at the start to make sure that you can measure it at the end, and that's going to show if people are getting better. So having, again, really good screening and assessment up front is going to be key to making it successful and making it work. So you need to bring in the right players for this. It's really essential to building staff trust to make sure that you're getting the input of all of the folks that work in your program, right? Making sure that you have the buy-in. Now, this doesn't mean that you have to keep going back to everybody and making sure that all the input is being all the way integrated. It doesn't mean that you have to make perfect, the enemy of good. But it does mean that you want people to have a voice in this. So they are able to say, I am concerned about risk, or I am concerned that we don't have this in place, or, I really like this assessment and here's why. They want to have their voice heard. So having that ability from everybody helps you to build that trust, which again is going to make this successful. In terms of that how, and connecting in the tools, the 3 handouts that we have attached today that you guys can access in the sidebar, I believe, in your webinar, give you guys actually some very specific examples of ways that this has been done on different units. So it will show you, hey, this is an example of when the clinical and the medical staff got together and we all found agreement on what would be the cutoff on a CWA or a COWS for someone to be admitted onto the unit, because we know that under this level or between these levels, we are going to be able to manage that from a risk standpoint. Okay. There's also a document in there that speaks a little bit to training. So this is the other key important part that links into screening and assessment is you do have to make sure that your staff have the appropriate training. So on my unit, what we did is that we had our nursing director come in and train our peers and train our techs on how to be able to appropriately administer a CWA and a COWS, and how to appropriately do some of these screenings so that they could administer them throughout the length of someone being there. And again, that's one of the ways that we manage risk on our unit, and also ensured that the individuals that were seeking care were getting appropriate treatment, and that they were having good interactions with staff, that they were feeling like they were really being supported and cared for on their journey. So in the tools section here, you'll see some examples of different types of screening or assessment tools that have been used. And here is an example of what some of the handouts look like that you guys, again, are able to download. So this is an example of an alcohol or benzo withdrawal procedure. And then an example of an alcohol detox procedure as well. So again, you'll see that there are very clearly written procedures and types of screenings and assessments that are used throughout this that really help to ensure proper care while somebody is on a unit. The next critical piece that you want to make sure that you're integrating into services on your unit to be successful are those MAT services, so medication assisted treatment. Elon previously talked a little bit about this and how important, having access to medication assisted treatment really is. So Elon, do you want to speak a little bit to what MAT looks like in some of your programs?
Yes, I think just to start off the bat, medication-assisted treatment is going to be one of the most functional ways to keep people within a program and not have them leave due to a crisis or leave due to addiction. It's going to help minimize a person's withdrawals and cravings and help them focus on the care that you need to give them. It gives them just a little bit of that feeling of taking the edge off enough to possibly allow the rest of your treatment to set in. And while there are a lot of hows pertaining to what you can offer when it comes to medication-assisted treatment and what it can provide support for, the most important of all of them, in my opinion, is accessibility. And that is, if you have a program that doesn't allow people to take MAT while they're there, because there are some facilities that still struggle with it being, in some ways, a controlled substance, that it's something to revisit and look at and understand that there's a lot of work being done in the legislative space, particularly on the federal level, to ensure that there would be increased accessibility to MAT in all settings. MAT being offered within the first day or two of somebody's admission into a residential facility is going to be vital, and oftentimes more vital than access to psychiatry for other issues that they may have within that period of time. So a person can't get access to MAT and start minimizing those cravings or withdrawals within the first 48 to hopefully never, but latest 72 hours. They're going to struggle with being able to remain in that program because they're going to start experiencing some sense of clinical withdrawal within their bodies. MAT is going to work primarily on different types of substances as well, and we're finding that there's an increased protocol when it comes to more substances. Many people are aware of the use of MAT when it comes to opiates and being an opiate agonist. A lot of people are aware of MAT as a form of medication to help smoking cessation as well, and alcohol treatment as well, where people can take something that then the use of alcohol will be not so pleasant for them. What we are seeing now is that there's recommendations, particularly for stimulant use disorders as well, such as the use of meth. People engaging in meth use, at least in our area, has increased dramatically as compared to opioids climbing, that there is specific regimented protocols put out by the ASAM committee. And you can find it online, and it's something that we can help access after this training if you need additional protocol information by reaching out to us, in regards to how you can prescribe for people who have a history of meth use and are struggling with meth sobriety as well, to help minimize their cravings and minimize their struggle when it comes to sobriety as well.
So an example of what this could look like, for the programs that I led, we had a multiple door approach for folks being able to access MAT services through our respite and through our CSU. We were lucky to have an emergency room right next door to where our CSU building was, and only a few blocks away from our respite. And so our crisis walk-in center was co-located with our CSU. They were in the same building across the hall from each other. So folks could come into our crisis walk-in, and if we recognized that they would need to access our, CSU, and if they were going to need maybe some MAT medications, we had an agreement with the emergency room. We could send them to the emergency room where they could immediately get started on MAT medications, and then we would admit them to our CSU where they could continue to receive MAT treatment, and then we could step them down to our respite location, and we would connect them to a community provider, whether that was through our local community mental health center or somewhere else, that would continue those MAT services long term. And then, people could enter kind of in any version of that system. So if they went directly to the emergency room, again, the ER could start those MAT meds right away, and then they could send referral right over to us to be admitted to our CSU or to stay in our crisis walk-in center for up to 24 hours, or they could go directly to our respite. So we could really use all of those services interchangeably. And by having a really good relationship with that emergency room that was right next to us, we were able to get really, really quick access and prescriptions for MAT meds. So that's one way that you could envision how your systems can kind of work together and how you can form partnerships in your community to really strengthen how that works.
Let's talk a little bit about the evidence-based practices that are accessible to you as mental health providers that are going to help with people who also have co-occurring substance conditions as well. One of the fundamental components of a crisis residential setting is the milieu and the community setting and the groups that are clinically offered and provided. It's vital that you offer groups and support for your clients that take into consideration a holistic approach, two of which are mentioned on the slide in front of you here, which are seeking safety and DBT. Seeking safety is an evidence-based practice that is designed around trauma and substance treatment. It's particularly a poignant treatment methodology because it's not a past-focused treatment methodology. It's a present-focused or future-focused treatment methodology. It doesn't ask people to go into their trauma, and it doesn't ask people to go into their substances. It just helps them regain control in their lives over the things that have been holding them back and holding them down. Even for individuals who don't have substance use disorders, there is the idea within Seeking Safety that anything can become unsafe coping, and it's a fundamental tool that's useful regardless of the population you have, that can be utilized in both substance users and also in mental health clients as well. Dialectical behavioral therapy, DBT, while providing in its full scope format, is a challenging experience to provide in a residential setting. The idea of the groups, which are skill-based and skill building, goes back to what we mentioned earlier, which is similar in residential settings to substance settings, where you are able to provide people with basic skills and information that they may not have had prior that has led them to the unsafe coping or the unsafe things that they're doing. Skills such as mindfulness, skills such as interpersonal effectiveness or emotion regulation are going to be wonderful things that can be used and taught, whether it's in a residential setting for substances or whether it's a residential setting for mental health disorder as well. And the therapy modalities that are really important, many of us are currently aware, is in crisis residential settings, we're not doing long-term in-depth psychoanalysis or psychodynamic work. We're spending a lot more time on either problem solving or a lot more time on resiliency building for individuals, both of which are going to be fundamental aspects of substance use disorder, substance treatment as well. The idea of utilizing evidence-based practice such as CBT as well, so that you are able to get people to identify hot thoughts and irrational feelings and considerations and teach them a method of stopping before they use a substance is a really important aspect of evidence-based practices within residential environments as well. We can add to that there are also some other programmings that you may consider as well. Depending on the breakdown of your program and how many people at a certain period of time have a substance use disorder in your programs, one of the things that we offer is voluntary NA and AA groups in our facility. We have a panel of AA or NA experts who come from the outside and will offer voluntary groups for individuals and also help them identify and find sobriety buddies and sobriety systems of care outside of the program. It's not something that everyone needs to attend, and it's something that's just there as an additional adjunct service that people can gain support from. And another non-clinical group idea, which is a phenomenal one in residential settings, is the idea of RAP, Recovery Wellness Action Plan. Having a recovery group where people can work on creating a toolkit of safe skills for themselves is a really vital aspect of providing care as well.
And don't forget about your peer specialists. Those are also, individuals that can provide groups that can do a lot of work on your units. So in our last couple of minutes here, we want to wrap up by speaking to billing and licensing, right? Again, what we had talked about kind of as challenge for some folks. Every state does their licensing, their billing, their coding a little bit different. And so, happy to give you guys some individualized kind of support and ideas around that if you reach out to us afterwards. A couple of things to think about is, are you able to potentially negotiate, with your service provider that you contract with? At my agency, we were able to reach out to our MSO and say, hey, here's actually all the services that we're providing. And so we're going to code it under a short-term residential treatment code, a CMS short-term residential treatment code. But because we're providing all of these extra things, we'd like to negotiate the rate for that bundle. And we did a bundled rate. For us, that was the best way to go rather than billing for each individual service. It really cut down on admin time for our staff and allowed them to provide more direct work. And, we had a really good relationship with our MSO so that we were able to do that negotiation for a particular rate here at that unit. We were able to demonstrate that we were saving them money because people would come to us versus lengthy stays at the ER or perhaps not even going to the ER at all. And knowing your regulations. For our CSU and our respite, we did accept individuals who needed SUD treatment and SUD detox, but it wasn't SUD only, right? So that was a big differentiator for us. It was co-occurring treatment. So they did need to have, you know, a mental health diagnosis that we were also really looking at as our primary thing that we were treating. And additionally, we provided that SUD support. So that's how we were able to manage that in terms of our licensing. We didn't have to license as a detox. We didn't have to bill SUD services separately. We bundled our rate all under one mental health code, but we supplemented and negotiated what that rate was. So something to think about as you guys are doing your billing and your licensing and how that might work for you. Finally, the last thing we want to really touch on, because it's super important, is that we need to make sure we're doing a really nice job connecting in our referral and discharge process, right? Our discharge should start at admission, really targeting what those things are. And especially, as Elon mentioned, if you're going to provide MAT services, you know, from day one, you should be connecting folks to a MAT provider. And by the time they leave your unit, they should have an appointment with somebody who is going to continue those MAT medications as well as continue treatment on the outside. So make sure you have appropriate referrals in place. It's really helpful to have, you know, a pre kind of set list of places that you're going to hand to people written. So that way, if they even discharge against, you know, advice, and before you have that appointment in place, they at least have a packet with written references and resources in their hand. So I know that we have covered a lot of information here, a lot of things packed, especially into the end of this presentation. We thank you guys so much for your time. And I'm gonna, at this point, turn it back over to Neolita, and if we have any questions that we want to answer as well.
Awesome. Thank you so much, Jamie and Elon, for presenting to us today. We do have a couple of questions. The first question would be, what modifications would you make if the majority of the program are substance users as compared to when the majority are not substance users?
A wonderful question. I think clinically, the first thing that I would want to ensure doing is to start creating more cohesiveness between the individuals who are in the program by increasing support through a peer perspective as well. That there are other people here who are experiencing similar issues as you, rather than isolating the substance users in a population where there's just one or two of them. And you can look around the room and see that everyone else is here because of the circular causality of substance issues in their life. You help create a little bit more of a connection and bond and use the terminology a little bit more openly. I think the big thing that I would ensure is the utilization of terminology that may be a little bit more specific to the substance field is discussed and shared. Maybe talking a little bit about harm reduction and the spectrum of care, talking a little bit about the abstinent approach and what an A or NA model looks like, and giving some more psychoeducation because it's a little bit more generalizable to everyone, rather than pinpointing one individual and making them stand out as the substance user in the group.
Yeah, and I would just add to that, I think, you know, as Elon pointed out earlier and throughout the presentation, the rate of co-occurring is really so high that I think I would be hard pressed at this stage in my life to find somebody who only has a SUD, you know, disorder or something like that with absolutely no mental health behind it. And so making that connection for folks and ensuring that we, you know, depending on the length of time you have on your program, you know, there are things that apply to both populations, right? So focus in on the things that apply to both rather than, again, like Elon said, siloing them out into these different groups.
Absolutely. Awesome. Thank you, guys. Another question is, what adaptations can be made to a program that does not cost any additional money or staffing resources?
Yeah. So again, oh,
go ahead.
For me, you know, I think about what kind of program you're running and what type of staffing you already have. Because if you're running a, this level of programming where you already have 24/7 nursing, because that's what's required for your crisis stabilization unit, it's really no extra cost to be adding in things like, now we're going to train our staff that are already there, that we're already staffed for, to do, our POWs or our CWA every hour on top of the hour, things like that. And we can get meds paid for by insurance for these folks and get them in or in stock. You can also find a lot of grants right now that will be helpful if you keep certain meds already on stock on the unit that you want to pay for. There are grants that you can apply for to help with those kinds of supplies and things. If you have a program where you only have nursing 5 days a week, right, then make sure that you are modifying your protocol to what's appropriate for that. For the respite program that I had, where we didn't even have nursing on site, we still ran what we would call ambulatory detox in that program. So our folks were free to leave the program to go to our crisis walk-in clinic and get their assessments done by the nurse there at that location, make sure that their MAT meds were all set to go, and return to the program. And we helped facilitate that transportation so that we could still provide that service.
I'll add one additional one, because I think the idea of something not costing anything is the most important part for me. Reaching out to and finding your local chapters when it comes to sobriety work in your community. So who is doing harm reduction work in your area? Who is doing AA or NA work in your area? And asking if they'd be interested in coming and speaking to your team and providing them with training so that your team can have a hands-on training on site. Asking them if they'd be willing to swap some of your space once a week for a AA or NA group, and provide that as something that you give. So when money is short, we oftentimes can swap time. You may be able to provide them a training or information about the services you offer and how they can refer to you, and they may be able to offer you information about how you can help your clients. When we don't have funds, we use ourselves as the commodity. And I think that's something that you'd be able to utilize with those populations in your community as well.
Awesome. Thank you guys again so much. This was a wonderful webinar with lots and lots of information. I do want to remind all of the participants that there are handouts in the handout section that you have access to with resources. Please join us for our next webinar, which is going to be Tuesday, May 21st. And we are going to be talking about looking for differences when everything is the same, behavioral health as a service industry. And you can go ahead and click on the QR code to get registered for that. You may also receive an email as well. We do also have our webinars lined up. So after the May 21st one, we have an additional webinar Tuesday, July 30th, talking about Culture Eats Strategy for Breakfast, building and sustaining a great culture in your crisis program. So please be on the lookout for those webinars and get registered. We want lots of participation. Lastly, our Crisis Con is coming up, our conference that we do yearly. This is our National Crisis Continuum Conference. Registration is now open. You can go to www.crisiscon.org and register for that. We will be in Phoenix, Arizona, October 14th through the 17th, and it will be a wonderful time. So please join us in Arizona in October. Again, thank you, Elon and Jamie, for you guys presenting today. And that will be our webinar for today.
And just so you guys know, I popped my name and email in the chat. I'm sure Elon would be happy to put his email in the chat, because I realized we didn't put that on our last slide, if you guys do want to send us any individual questions.
I'll leave it open for them to copy that.
All right. Thanks, everybody, and have a wonderful rest of your week.
Have a great day, everybody.